everybody. Welcome to Sessions with Adit. I'm very excited to share with you a very special guest we have today, my dear friend Christina Orlova, and I will let her introduce the amazing work that she does. I really hope that this session that's going to be very much focused on anxiety and mental health is going to be of value to you. So with no further ado, Christina, welcome.
Thank you.
I would love for you to share a little bit with our viewers on what you do and who do you see? What's your specialty? Sort of introduce yourself.
Yeah, so over the last couple of years, I've really niched down and specialized in obsessive compulsive disorder as well as other anxiety disorders like social anxiety, phobias, body dysmorphic disorder, generalized anxiety. I think there's probably some other things I'm missing right now, but predominantly most of the folks I see are folks who are dealing with obsessive compulsive disorder. Essentially for that, you have to go through a specialized training. And then once you do, then the rest of it, I think, just comes with doing the work and kind of seeing folks day to day, learning the nuances, the different ins and outs of how this manifests and how to best support people.
And how long have you been, Christina and I have actually worked together for a very long time in mental health. So how long have you been in mental health? What's your specific, what is your specific title, your credentials, your certificate?
So I'm a licensed marriage and family therapist. I've been in the mental health field all in all, I think at this point, 10 years, something like that. Kind of went the gamut from working with elderly and working with folks with Alzheimer's, worked with San Francisco Suicide Prevention team along the Unified School District. Then did trauma work. That's where we met. Did that for I don't know how many years at this point, but a while. Took a break and then kind of got back into it and really went into OCD and anxiety world. Honestly, it's been an interest for a while, and I myself had a lot of misunderstanding of what it was. And then once I started doing the work and learning more, I just fell in love with it. I love the style of work. I like the fact that you really can help people get results. Of course, like anything in life, right, there's a variation in terms of level of severity and what support needs to look like. But yeah, I think at this point it's been definitely about 10 years.
I love the passion. I know how much you love working with anxiety and working with people to just help. And I think for you, knowing who you are personally and professionally, that seeing results is so important. And what really results mean is people get the help that they need. People are suffering in their mind, and that also means that they are suffering in their life. And to be able to actually see somebody not suffer anymore, like you feel like this is the work that matters to me, and you've been able to experience the impact on how you work with folks who are struggling with anxiety and struggling with obsessive compulsive disorders,
right.
And to be able to bring things that work to them to change their whole life. Like, that's why you do this.
100%. And I think also just probably you've seen in your own practice that when folks don't get the right treatment, or how many times there's just misinformation, and directly when I sit with clients for just an initial assessment, how many times they'll tell me, oh my gosh, I've had talk therapy for, 4 or 5 years, or I went and did all these other modalities, or I tried all these other aspects and nothing helped, and in fact I've gotten worse.
Okay.
Right? And I mean, part of it is when you're working with a modality that's scientifically based, and there's enough research at this point, right, that really shows like this is what works, right? Why would you then not do that, right? Like you would want to do what works. Like if you're feeling sick, right, you're going to want to take the vitamins and drink the tea and have your soup that works, that's going to make you feel better, and go to sleep and rest. So I think similarly, especially when it comes to OCD specifically, and some others like body dysmorphic disorder, there's certain elements within that treatment that's a little bit different and unique, and it is really important that people get the right the right treatment.
Right.
Because like I said, the wrong treatment actually can cause some damage, and people can have they can kind of spin out a bit more in terms of their obsessive content and things like that.
I love that you said that, like getting the right treatment, because I think mental health, one reason why I love doing this and to expose and talk about mental health is because people are very comfortable to go to the doctor if they have the cold, if they have the flu.
Right.
It's very easy. I have the sniffles, I have a fever.
That's right.
Signs and symptoms are clear. You know, no one judges you. In fact, they encourage you to go to the doctor and and get help so that you recover more quickly and you don't spread your germs or you don't spread your illness.
Yep.
And but we don't do that with mental health. We don't really actually encourage people to go see a specialist if you're struggling with anxiety. And I think one reason too is what you said earlier. There's a lot of misconception, and us being in the field, there's still misconception for us. So I can't imagine for folks who, you know, this isn't your world every day, that you don't even know maybe you have symptoms or signs of anxiety, so you don't even know where to go to get the right treatment. So maybe we can even just start there with, what is anxiety?
Well, I mean, if we're going to talk more broadly about anxiety, essentially, I think most people will recognize is things like there's a lot of worry that comes with it, right? There's a lot of what if kind of questions, like what if this goes wrong, or what if that doesn't happen? What if I get fired? What if like I'm having something, my heart is racing and something's wrong and maybe I'm going to have a heart attack. So it's very connected to that cognitive aspect. And also the part of the brain that's impacted is the flight and fight response. So that's where you have physiological symptoms. So like I mentioned, the racing heart, some people have really sweaty hands, some people get really cold sweats. I've had clients have things like where their eyes kind of glue shut and they have a hard time opening their eyes. You can have butterflies in the stomach, you can feel nauseous, lightheaded, dizzy, dry mouth, and multiple of those things can be happening at the same time.
So Christine, let me ask you. So a lot of people will be like, oh, that's me. I actually, every now and then experience the butterflies. I experience the sweaty palm, like hands before I have to give a presentation. So anxiety can be experienced by almost everybody. So what takes it from being just a day where you're experiencing some nervous jitters to like it being a disorder that you actually should start seeking treatment? Like at what point does someone say, I actually should start seeing somebody? Or what are the signs and symptoms for like a family or friend if they see a loved one, just like they would encourage them if they have a fever to like go, you know, above 102, like go to the ER or go to the doctor. What would a family or friend need to see in someone that they love for them to say, you need to go see a specialist?
Yeah, I mean, it's a very good question. And I think a really good barometer is like any of us can have down days, right? You can feel kind of low mood or you can be a little anxious, like you said, but that's kind of right in itself is the explanation. It's some days it's kind of low, you can shake it off, you get up and you get back into things. When you're impacted to such a place where your basic functioning is now impaired, you're just at the thought of, let's say, going to work, your anxiety and your nervousness goes through the roof, and now you're starting to not go to work, for example, you're starting to skip, or you're starting to isolate more, and now you're withdrawing from, let's say, when you typically see your friends or family, or let's say typical activities. So you want to kind of start to look at the behavioral patterns. So usually when folks are impacted in the most common kind of life domains, if you will, and they're not able to engage in them, that's when you want to start to say, wait a minute, something's not quite right? Because again, any one of us can have, even let's say for a couple of days, it might last where you're feeling really nervous and just right? Or you might go to the gym to try to get it out or go for a jog or something. And that's normal, right? But now again, if we're talking about now it's been a week, 2 weeks, 3 weeks, 4 weeks, right? And the more time progresses, the more and more incapacitating it is. And now you're really not able to re-engage, right? That's definitely going to be a time to seek some help.
So at what point does someone come to see you? Like on average, a client that you're seeing, at what point are they in their life that they come to see you? Have they lost their job at
Yeah.
that point? Have they lost relationships at that point? How far in are they on average by the time they get to you?
So I think one thing I want to say is that most of the people I see are dealing with obsessive compulsive disorder. So it's one of the anxiety disorders. Low percentage of folks I see who maybe have like social anxiety or a basic phobia. Basic phobia would be like fear of heights or fear of being in a tight space, like claustrophobia, fear of needles, things like that. So with OCD, usually what I tend to see, and this is actually pretty common, is that folks have been trying to find treatment or have undergone treatment, or maybe the wrong treatment, or maybe even the right treatment, but something about it maybe they didn't get or they forgot. But usually they've been in this for anywhere like up to 10 years. So it's not common to see somebody that's just kind of started to have symptoms, and then they're in treatment within 2-3 months. I have had a couple of clients like that, so it's been interesting to watch folks when they're able to catch it on that front end right as things are happening, and they happen to be the right specialist, the right psychiatrist, and we come together as a team and say, this is OCD, and this is the subtype of your OCD. And so with those couple of folks, we've been able to really help them more quickly so that things are not as entrenched. But typically when folks come, they've already been going through it for a number of years. Usually it's very much, especially we're talking about moderate to severe level of intensity. Absolutely, people have either lost jobs or the family dynamics are really strained because everybody's really exhausted, because they typically will pull people in to accommodate them or to maybe engage with them in their compulsions and rituals. And we could talk about what that means, but essentially, relationships get very strained, and things can be really challenging, and everybody wants help, but people don't know what's happening, right? So they don't know what to do or how to do it. So usually when I see folks, they're definitely in that place of like, I need help yesterday.
Yeah, 10 years is a long time.
Yeah.
And I can see how easily it can just start to get worse and worse and worse over time, right? And you're sort of questioning like, is it just like my mood is off for a little bit, it's just general anxiety I'm just experiencing, and then
I think some people get misdiagnosed as the issue. So if somebody doesn't specialize and doesn't know what to look for, they can get put in the category of like generalized anxiety disorder, when actually it's not that. Or it can look like, maybe you're having like a psychotic break, but it's actually not that either, because these are thoughts you're having. They're not hallucinations. You're not auditorily hearing things or seeing things.
So what's the difference between, from your experience, someone who is struggling with OCD? What is happening in their world, in their mind that...
Yeah, so first of all, OCD is a neurobiological disorder. Okay, so to really grasp what's happening, one, there is a biological component, so that you already have that predisposition. Then you, of course, look at the whole context, like what was the environment like? Are there any stressors? Usually things like for kids, PANDAS is a common thing, like strep throat. That if a child already has that predisposition, they can literally within a couple of weeks start to exhibit really severe symptoms of OCD. And I've had a case like that, handful. Then you have things like trauma. You can have emotional stress. You can also have a brain injury. So if somebody already has that, usually they might not connect the dots, but whenever I've sat with folks and asked them about what's their earliest memory and they start to think back, they'll start to connect the dots and realize like, I used to do X. Like I used to have to have everything lined up. And the thing that with OCD, it's that it's a doubting disease. So what's happening, basically there's a part of the brain called the basal ganglia that's impacted. So the communication center in the brain is not working properly. So essentially, if you can generally detect an error and respond to it, for somebody with OCD brain, their error center is misfiring. So they're not able to distinguish for a period of time is something wrong or not? Am I in a burning car or not? Did I clean that or not? Did I lock that door or not? I'm not sure. So they're constantly questioning. They're constantly unsure.
And what does that do in the body? Like, how does that then?
Perfect. Right. So that's the prefrontal cortex. That's the hot seat right here for OCD. So it triggers the flight and fight response, that limbic part of the brain. And so when this part starts to get really high, like the feeling thermometer, as I call it, right? Or in the OCD land, we call it the feeling thermometer. So your physiology starts to change. So you're having a thought that's uncomfortable, and it's paired with this physiological reaction. So like your heart starts to race. So typically, if a person has that combination, they're going to say, oh, that must mean something. Something's off. And usually, right, when this is firing properly, when it works, is to protect you, right? So like if a car is coming down the street, right, you're not going to think about it. You want to react. Like, boom, get out of the way, survive.
Like, I'm not trying to get hit by a car.
That's it, right? But when it's not operating properly, then it's misfiring. It's your internal alarm system firing at the wrong times over wrong things. So now you can't tell. So now you're having a thought that's not comfortable. You're having this physiological reaction with it. So of course your intuitive response would be to do something about it because something is off.
And the doing something then is...
That's what becomes the compulsion, because now you're trying to basically make sure that this
Control it.
bad thing that your brain says could happen doesn't happen, and you're trying to get rid of this anxiety. You're trying to stop that sensation, that feeling. So it's this attempt at, again, mitigating the danger, so trying to be preventative, right? And also trying to reduce that discomfort. But the fact is, it's misfiring at the wrong time. So when you're responding to it at that time, you're essentially reinforcing and making this connection in your brain that thought and that sensation, those equal danger.
Can you give an example of like what that actually, like what does that
sound
mean?
like?
What's the thought? What's the compulsion? And then what's that?
So something really basic I think most people can connect to, right? Like everybody leaves their apartment, their house, and you lock the door, right? Everybody, I think for the most part, you lock it, you walk and go, let me just check. You might check once, right? So right in that moment, because your brain for a second, you maybe weren't sure, you check, you feel like you got it, you walk away, you're done. That's it. For somebody with OCD, when they go, they lock and they walk away, their brain goes, oh, but maybe you didn't fully lock. So they're going to go back and check. Now that they checked, let's say they shook it, they checked it, they start to walk away. But again, because remember, the communication center is not processing everything all the way.
This is the miscommunication, misfiring.
Exactly.
At the
This is where
wrong
this
time.
loop isn't closing. So now you're walking away and now you're like, yeah, but maybe I didn't check. I didn't pull hard enough. Maybe I didn't check well enough. Let me go one more time. Now you go again. Now you might pull at the door, push at the door, just to see that, okay, it's closed. You start walking away again. Your brain again goes, yeah, but maybe. So that's what starts to happen internally, is you're starting to have these doubts. And you're unsure, well, wait a minute. Did I really pull hard enough? Maybe I didn't. Did I really check? I'm not sure. So let me go again. And now you can be stuck in that cycle for 5 minutes, 10 minutes, 15 minutes. I've had people come in with like 50 pictures because they're trying to be certain, right? They're trying to get that certainty that, okay, I did lock it, it's done. So that's why it's known as a doubting disease. And what the behavioral response is geared towards is to try to get that certainty, right? To try to make sure that, okay, I did lock it, it is done, nothing bad will happen. Or, the reality is we all have random intrusive thoughts, every human being, right? Like random, like, oh, what if I didn't turn the stove off? And then you're like, yeah, no, most likely I did, right? And you're able to recognize that as garbage thinking. You toss it, you move on.
And you just move on from your day. You're
Yeah,
able
you
to
move
go back
on.
to work. You're able to go back
Right,
and engage
average
in
typical
conversation.
person, right? How many people drive and go, oh, bicyclists, what if I just tap them, 20 points, right? Everybody always makes people make those jokes. I don't know about you, I've heard it when you're friends with, right? In a car with friends. People constantly making jokes about tapping a bicyclist. Right, like a little game.
They get in the way sometimes.
Well, right, but see, people laugh. People
Yeah.
go, oh yeah, haha, but you toss it, you
Yeah.
move on. You're
Yeah.
not stuck on it. Now, a person with OCD,
Yeah.
because they had this thought, and now it's accompanied with a very visceral reaction of alarm. They're now thinking, wait a minute. Well, what if I did and I just can't remember? right? So now,
what if I tapped?
Yeah, what if I did do something and I can't remember? What if something did happen and I'm not sure right now. So there goes the doubt. So now the person's gonna go around the block, come back
To see if they
and check and look. Did anything happen? Is anybody on the street? Is my car clean? There's no blood? Everything's good? Trying to get that certainty. They're gonna start driving. There goes the brain again. Yeah, but maybe you didn't check and they still could be on the side. And you go, oh man, let me go check again. And that's how the cycle starts. Now, the thing is to understand is the process of how OCD brain works is the same across all cultures, genders, doesn't matter.
What do you mean by that? Can you share more?
Meaning how the brain misfires, that's for everybody. Basal ganglia is a basal ganglia. Every human has a basal ganglia.
So there's no discrimination.
Nope.
OCD, anyone, anywhere.
Nope. Right. And this is also, I think I mentioned before we even started, that this is like the most diverse population I've ever worked with.
Can you share a little bit of like age range, culture,
Yeah.
race, like religion, like who do you...
I mean, literally, I've worked with folks from literally Africa, Iran, Pakistan, oh my God, I forgot what part of India, but India, Eastern European, American, Latin American. Yeah, like right now, even my caseload is pretty. It's very mixed. It's very mixed.
What
And
about-
age ranges, I mean, I work with like anywhere from 10 upwards. So right now it tends to be a lot more millennials, interestingly enough. But I mean, I've worked with teenagers.
So what about a 10-year-old or a younger child? What does it look like could it look like in a younger child than an adult what does it look like at 10 years old? And then that 10-year-old, if not treated, what do they look like 10 years later?
Yeah, that's a really good question, actually. So depending on the subtype. So one thing I think people don't know is that there's not just a couple of subtypes. Like contamination is one people commonly hear about, but that's just like one thing on a spectrum of things.
What's contamination?
Like being afraid of getting dirty. Like if I touch this table, like I might not know how you clean this table or what else was on this before. So if I touch it, my brain tells me the signal that, oh my gosh, what if there's something on this? And now it's going to be on my fingers. It's going to enter my bloodstream, my cells, and now I'm going to have it in me and I could die. Or what if it does something to me and I get sick?
So is this someone who is going to go now pair washing their hands to lower their
or they might
anxiety?
just sit here and kind of close off and avoid it altogether. So the thing is that, first of all, there's at least 15, 16 subtypes that we know of and more. So this is what I was going to say is that the content of the OCD really depends on the person. So whatever the person really cares about most at that point in their life, that's what OCD goes after. And that's why people, when they start to have all these doubts and uncertainties, it really goes deeper than just that face value of doubt. It really starts to target kind of your sense of self, right? Because you start to not trust yourself. Like, wait a second, am I maybe capable of doing this bad thing that my brain is saying? Or could I possibly get sick like that and die? And what if I infect other people and then I'm responsible, right? So it really hits on that deep core level. And so if you're a younger child, like 10, and maybe your fear is that you did something wrong, right? And so now you're constantly coming in and asking for reassurance, like, mommy, daddy, did I do something wrong? Am I okay? Are you okay? Are you mad at me? So it can look like that. So you're incessantly, constantly asking for that. And, I had a kid I did an assessment for. This kid was like 7, and essentially would not be able to let her mom leave until she said, I love you a certain amount of times, and she had to say it a certain way. So then she could feel like, okay, we're good. But that was the accommodation. That was now looping your parent to now do a compulsion with you until you felt good and certain and like you can be done. For the most part, you're never really done, because it never quite feels satisfying. You're always there's always for
that
every
doubt.
time. Yeah, exactly. For every time you use logic and rationale and you think you've answered it, you figured it out, guess what? There's always going to be a what if scenario. Yeah, but what if I miss this, or what if that? So that's why when we talk about treatment, it's really critical to get the right treatment, right? Because a lot of folks will say, well, let's just do some basic standard CBT things like a thought log, and let's restructure your thought, Well, that might be a right strategy for, let's say, social anxiety and other anxiety disorders, and maybe even OCD, but down the line. When you're initially needing people to learn to separate and distinguish between your OCD-driven content and thoughts and feelings versus you at baseline, you are not going to be able to use that strategy, because if you're going to start to use a basic thought login, for those who don't know what that is, it means you're
tracking your thoughts.
You're tracking it. You're looking for evidence for and against the thought, what supports the thought, what doesn't support the thought, and coming up with an alternative thought. So right there already, inherently it's built in for you to start to engage in more of the what-ifing, more doubt. So a person with OCD, that's not going to be the right tool. And often people who come to me and tell me, yeah, I've had CBT, I'm like, well, tell me a little bit about it. And they tell me, oh, I did thought logs, I looked at evidence for and against my thought. And I'm like, and how was that? And they go, wasn't that great, because I would leave and I'd have more thoughts and more doubts and more what ifs and more anxiety and more worry, and it was just like I would spin out. And I'm like, exactly, because that's not the right strategy for you at that time. Right? You first need to learn how to separate yourself and recognize it's a thought that you're having. You may not like the thought, right? It may be morally not acceptable to you because of whatever your cultural background, your religious background, whatever context you're coming from.
Right, because it can be more severe than just germs, or it could be more severe than did I lock the door? There's even thoughts of like, I'm so scared I might kill somebody. I might hurt somebody.
So for OCD, kind of the bigger kind of topics are harm OCD. So this fear, like, what if I could hurt myself or somebody else? And again, OCD is an anxiety disorder, not an impulse control disorder. So that's the difference, right? With OCD, it's I'm scared I might, because I'm having this thought that I could. What if that means I will, right? So you, again, go right back into all that doubt. Sexual content. So it could be things like, what if, like a very common one, pedophilia OCD is a subtype. So what if I accidentally, like when I looked at a picture of a kid, I don't know, on a cereal box, I don't know, on a bus marketing, whatever thing. What if, because when I looked at it, like, I get this anxiety, oh my God, does that mean that maybe like am I into this picture? Do I like them? Do I like this? Oh my gosh, then what does that mean, right? So you start to get completely kind of spun out because you're not sure. Again, because you're having this visceral reaction. So now you're assuming it must mean something.
And this is the basal ganglia misfiring, miscommunicating. And
well, this is several parts of the brain, but one of them, yes, is the basal ganglia. This is the prefrontal cortex, where a lot of the thoughts and the processing, the air processing center is, and then it triggers the flight and fight response. So now you're feeling kind of out of it. And when the flight and fight is really on fire, you can't think clearly. So now you're going to be even more apt to have distorted thinking patterns. So now you're definitely going to misread situations, right? But because it's so hot, right, you can't tell what's happening, so you get stuck, and that's exactly what happens. You're stuck in this loop.
So right? Someone who has OCD, to do a thought, like tracking your thoughts and correcting them, that might work for someone with just general anxiety disorder, or
well, and it could even work with an OCD person, but down the line, right? So you first need to help them really use what's called exposure and response prevention strategies. That's one format of CBT work. So learn how to do that work so they can start to distinguish between what is my OCD false alarm and a real threat, right? Because flight and fight response, it's our alarm system. We need it for survival.
So what do you do in regards to, so someone comes to you, they've been struggling now at their home, in their relationships. How do you help them? Like, what is the treatment that you do that's the right
$1 million question? Yeah. Well, essentially, I mean, there is a protocol that you want to follow, and when you know the protocol and how to do it, really the magic is in the individuation, because everybody's so unique. So you really want to be individualizing the treatment. So essentially what you want to do is, step one is always psychoeducation, right? So I really am big on helping people understand what is happening to you and why, right? Because when you can understand why I'm feeling what I'm feeling and what is happening and why, then I might interpret this to be dangerous or bad. It kind of helps people get a little bit of sense of what's going on, so they can relax a little bit. Then we want to do what's called a fear structure analysis. So now we really want to grasp and understand kind of the full spectrum of how's your OCD manifesting. What are all the different internal thoughts, or maybe they're images or worries or fears that start that anxiety cycle? What are things that are happening externally around you that when you're in that environment or when you see these things or interact with these things, they trigger that cycle? And then what are you doing in response to that? It can be internal. So people can sit and look like this, and you might, if you don't know what you're looking for, you might have no clue that right here and right now I would be compulsing, right? Because again, it doesn't have to be outward. You don't have to see it visually. People, like, we're human, we're really adaptable creatures, right? So we will adapt. So if I know in my environment, like, oh, I really can't do this thing I want to do, guess what? I'll find some other way. So people can start to count in their head. They can repeat words. They can start to trace letters. They might mentally ruminate. They might try to attempt to figure out a solution. And often lately what's been coming up with my with the clients I see, and I swear I'm going to do a training just on this, but it's where you think you're thinking, but you're compulsing. Because it sounds like, and it could look like you're actually analyzing and problem solving and figuring something out, but you're actually not.
Can you give an example of that?
Absolutely. So I had somebody recently who had come in, and she had said that for the last 3 years, she has had these repetitive thoughts about being unsure about her sexual orientation. This can be a hot topic for people, so just warning. But for the most part, from clinically and personally, when people are dealing with sexual orientation issues, usually people fairly quickly figure out, like, yes, I'm attracted to the same sex, or no, or I'm attracted to both, or whoever you're attracted to, right? Pretty much people get that clarity usually sooner than later. And usually then the question is, like, how do I tell my community or my family, or will I not tell? What is it going to mean? So it's a whole different set of questions, right? For somebody with OCD, you're suddenly are getting stuck on, what if I could be? What if maybe I am? I'm not sure. And now this person, for example, for 3 years, okay, is still going over the same territory, thinking that she's thinking, right? So she's thinking that I've thought about it in the past. I've tried to think about my other, let's say, interactions with other mates, or when I looked at other females, was I actually attracted to them or not? And as I'm listening to her describe this, I kind of paused and I said, well, let me ask you a question. She goes, yes. I said, how long have you been doing this again? She goes, 3 years. I'm like, and are you any closer to figuring it out? She's like, I guess not. I'm like, right. So what have you been doing? She said, I guess still on the same. I'm like, right, you're still on the same content and you're literally cycling through it. You have more questions, but you've never figured it out. Not once have you gotten even a step closer. That's OCD. So that's why we say OCD is a liar, it's a trickster, right? OCD's job is to get you to do compulsions. Because when you do compulsions, it's like you're tending to a bottomless black hole. Bottomless. There's no end.
And can you give a little bit more example to compulsions? Like, what does that look like? What does that mean? How is that defined?
A compulsion is any overt or covert behavior. So it can be internal in your head or it can be external physically that a person engages in to reduce their anxiety or mitigate the danger. So anything can become a compulsion. But really the whole aim and goal, when somebody is not sure if they're compulsive or not, I will ask them, what is the function of the behavior you're engaging in right now? Like this behavior, like of, let's say, mentally reviewing your past. What's the function? Why are you doing that? And people usually have pretty good insight with OCD. So they'll say things like, oh yeah, I'm doing that because I'm trying to remember so that then I can be sure, and there we go, certainty, right? Yeah. So I can be sure that I did or did not do that, or I can be sure that I did like this or I didn't like this, or I'm trying to be preventative ahead of time so that whatever I think bad thing could happen doesn't happen. Because OCD, because it's definitely driven by those fears, right? There's always gonna be this feared consequence that basically kind of like dangles that carrot in front of you, right? Like, well, if you don't check though, this thing could happen. And people go, oh my God, okay. Right? So you always take it because what if? You just don't know. Right? So again, we're back to that what ifing and back to that doubt. So in OCD land, all roads lead back to doubt. Constantly doubting.
One thing I know that people have actually reached out who knew you were coming on. I was interviewing you, were asking, which I imagined a lot of people would have this question, is, well, how long is it going to take? How long is it going to take for
treatment
me to get better?
Yeah.
How long?
Very common.
When am I fix me? When am I going to get fixed? When am I going to get better? What is
so
your
this
answer
is the
to
spiel
that?
I give to people that I see in just my initial assessments. Okay, so science literature says it really can take anywhere from 12 to 16 sessions. Okay, the reality is, like, I can teach you everything I know under the sun. You're going to be the one variable, right? So how you're going to be learning, taking the information in, how you're going to be committed to doing the practice so that you can keep learning, right? That's going to be what matters. It's not whether we can teach you the tools. We can teach you, right? It's going to be how are you going to then actually implement it. Right, when I've treated folks and they need to come back for a booster and, oh my God, Christina, this new thing is happening, and we're talking, and I said, okay, well, are you using this strategy? Are you using that strategy? And it turns out, oh no, I'm not. Okay, well, the strategies work, but you need to implement them. So the reality is this: it depends on who's sitting in front of me and what's going on with them. So if somebody comes and says, look, I really like finances are tight, it's an issue, but I do need treatment, I'll say, great. As long as I know that out front, I'll make sure to deliver the treatment in such a way to really maximize giving you those strategies. But you're going to have to recognize you have to do your part, right? And you're going to have to do the work in between sessions to really make sure that you're getting and learning and practicing, right? This is not, behavioral treatment is really different than just talk therapy, right? You don't just sit there and come and process and then that's it. Like, you're going to come, we're going to talk, we're going to have a plan, and then you have to practice. We'll practice in session. The expectation is you practice outside of session. Because otherwise no new learning can take place. And a big part of the work with exposure work in response prevention is teaching people how to do it right. Because there's a lot of folks I've seen, unfortunately, who, for whatever reasons, didn't quite learn the full protocol, or didn't finish it all the way, or the way they heard it, maybe something was missed. So there's some cleanup work I've had to do with folks. So really teaching you what it actually means, how to actually do it, and then having you practice is going to be really the most important element of the work, right? And so if you're not doing that, or if you're at least not going to somebody for even minimally 8 to 10 sessions, right, then I mean, you're going to have to wait a little longer until you can finally get the right treatment. But really, like I said, I've had people come in for as little as 8 sessions and be with me for as long as 36. So it just really depends on the person and also the level of severity, right? If you're a little more moderate to mild, you won't need as many. If you're more moderate to severe, you're going to need a little more assistance.
And it sounds like the earlier you come and treat, the quicker you can, maybe like at 10 years old you come in versus at
well, the thing with that, because it's a chronic lifelong condition, it's if you come at 10 because you're still, a little one, your brain is going to learn, we're going to use child-friendly language. So you might still need to come back at some point as a teen and kind of have a booster, or maybe later as an adult. The thing with this treatment is that it works. The other thing with this treatment is you do need to, historically what I've seen, people do need to come in every so often and kind of do reviews, do repeats, do refreshers, boosters, because it can morph, it does morph. You might have a couple of different kind of subtypes, if you will, going on, like fear of harm, fear of contamination, something else. And later on in life, let's say if you're a woman and you decide to have kids, guess what? Your values just changed. So what's more important to you now is going to be your babies. So now, right, your anxiety and OCD brain might suddenly shift gears in terms of now what it's going to care about and the content it's going to focus on. So we really have to kind of look and understand the full lifespan, and depending what a person is going through and what's most important to them at that time. But again, the strategies work. Whether you're 10, whether you're 18, whether you're 28, whether you're 38 and onwards, right? But it's just making sure that you're able to plug into the right specialist, right, who actually understands and knows and really get that treatment. If you need to be in it ongoing, that's fine. Like I said, I had somebody for a year, And then finally, even for me, I'm like, look, I think take a break and go execute. Like, you need to practice, right? And haven't seen this person in months, and just recently came back for a booster. And as we talked a little bit about some things, I kind of was able to more quickly identify what were some of the loops and remind her. And she was like, oh, right, got it. I'm like, great, see you in a while. Right? Like, we want you back in life. We want you completely immersed. Go, live, do. Right? So we really are wanting people to be up and running completely back into everything they were doing before as quickly as possible.
Right. It's a results-oriented treatment. So you being able to see you get back into your rhythm and routine.
Yes.
So what would it look like for someone who never received treatment? What would their life look like? And what does someone who's come in, had the sessions that were needed for their specific OCD subtype, and then what does their life look like? So the two, someone who is not getting treatment, not seeing someone, and someone who has, and what's the starking couple differences?
I think, this is where like numbers game comes into play, because like 12.5% of the population has OCD, so it's actually extremely common. It's like 1 in 50 or 1 in 40, something like that has it. So again, depending where you're at, there's like 2.5% of the population has OCD to the level where it's clinically significant, meaning it really impacts your functioning. About 10% is where it's subclinical, meaning you could have obsessions, but even if you do some compulsions, it's really low level, so you're able to get through day by day. So if we're in any one person who's in that more mild zone, at some point it can suddenly jump up. So essentially what it means is, if you're not getting treatment and things are suddenly, for whatever reason, they're triggered and they're up, and it could happen at any point, right, is that suddenly what very often people say, they have the sense like they feel like they're losing their mind. Like, I'm having these thoughts and now I'm having a lot more of them. It's getting louder and I can't stop it, right? So, and also at the same time, I'm having this very visceral physical reaction, like my heart's pounding on my chest, or I can't sleep, like I'm walking around and I can't seem to kind of calm down and get any kind of sense of like respite, or some people find, again, this is when it really increases in the level of severity, or it can be things like, I'm like really kind of taxing, but I'm using like my support systems or my parents. Very often it'll be a significant other or a parent or a sibling or somebody close that you're constantly using to kind of help you get that certainty and feel better. When you finally get treatment, we really want you and that whole system involved, so that we teach everybody the psychoed, so everybody grasps what's happening, and really teach your support system how to respond to you differently to maintain the gain. So we start to teach you how to tell the difference between when you're having an OCD thought versus when it's you, learning how to to differentiate between the thoughts and the feelings, learning also with anxiety how to really start to embrace it and kind of increase your distress tolerance. So we do a lot of that work. And then we teach also your friends, families, significant others, how to use certain language and also certain strategies and tools to support that, so that you're not just turning to them and doing the same thing before, but now they might say, hey, that sounds like it might be OCD. Is that OCD? Right, to help you be accountable. If you're seeking reassurance, we'll start to put guidelines in place. Like, okay, you get to ask one time, you get an answer one time, and that's it. And if you're going beyond that, you might want to now ask yourself, like what's going on here with this urge that I suddenly have, the strong urge to want to, again, get that reassurance. So we'll really do that evaluation with everybody to understand where and what kind of guidelines we need to put in place, so that you continue to be clear about what behavior is actually needed and what behavior is useful and what behavior is really not useful, and you really just engage in that behavior because you just didn't know any better, and now we need to work on getting rid of it.
Do you have any advice on or tips that you would give a family, friend, or a loved one who has someone in their life that they may notice these ways that OCD might be into? They might not know it's OCD, but they see that their family or their friend, their loved one is struggling. They might not even feel comfortable talking to them about it for whatever reason. Maybe that person doesn't feel like anything is wrong or doesn't want to talk about it. how can they even remotely try to open up the conversation for them to go
I
get
smile
help?
because I think have this kind of question like every day with the phone calls that I get. Like it's always some parent or somebody saying, well, what is, like I just had it today. So one is I always refer people to the International OCD Foundation. That's iocdf.org.
It'll be in the notes.
But I do refer them to that because IOCDF, there's ample amount of resources and information there. So if somebody's not sure how to talk about it or what it is, you start there because there's just a ton of reading material so that you can educate yourself a little bit better. And sometimes I'll say, send this or give it to your whoever that happens to be, that person that you're not sure if they're willing to talk about it, and have them just kind of look at it on their own time. That would be one. Another one, I will often, when parents ask me these questions, I will say for now, you might want to help that person start to get a little more reflective. So engage in questions like, are you noticing that, you were saying it's not a problem, but are you actually, if they're seeing that it is a problem, ask them questions about it. Like, are you noticing though, are you actually able to get to work on time? Or are you actually still able to hang out with your friends? Are you able to tolerate these things you were saying are not a big deal? Another way, like with a mom today, I told her, why don't you try to do a behavioral experiment? If your son is saying this is a non-issue, say, okay, if it's not, then would you be willing to just let's just test it out, like any experiment? Let's just design an experiment and see what happens, just so we can see if in fact you are having accurate information or not. So it's just a nicer kind of softer way to. With kids, it can be a little easier because you can make it like a game, and kids love games. So it's a fun way to engage in that manner. But that's the thing with this treatment. It's not forced. You really have to have some level of motivation for change. And that's why sometimes, unfortunately, it's just human nature, right? You're not going to be willing to do something until something really happens and you realize, okay, I have to, right? So if people are able to maintain a certain level for a while, they will, right? Until something really happens when they realize, okay, look, I can't do this anymore. Like I need to do something about this because this is just not working anymore. And that's very often what I hear. People, that's why it takes people a while, because for a while they can really maintain. And then something changes and suddenly they just can't maintain it anymore. It's just really, there's a break, something happens. And like I had a girl who was telling me that she was fine. And then she's like, I started noticing that I was having a harder time getting out the door to work. And then that turned from 15 minutes to 30 minutes to an hour to 2 hours. And now I'm like significantly late to work, unable to answer my emails, tend to my basic job duties and tasks. And now I'm being put on probation and I might not have a job. So right, so it can really get to that level. I had somebody else on a very severe end where, having a hard time getting out of the bathroom because their brain is misfiring and they're not sure if they're completely got themselves totally clean. So they're stuck in the bathroom. And we're talking about like skin is ripped, like, right, you're over showered, you're over, right? So your body's not doing well, but you also can't get out. So it can be extremely debilitating.
Yeah. If someone is ready for the change and ready to get the help, where can they find you, or how can someone access you? What are the projects or things that you're working on that you'd like to share?
Well, for me, so I do part-time virtual practice, and that's under coreresults.com. And that's more if there's mild to moderate level, and there is a way to test that. It's called the Weibach Yale Brown Obsessive Compulsive Scale. So I will administer that so we can kind of see where you're at. And if there's something more severe going on where you might need an intensive outpatient program, meaning that you're at a place where it's hard to get to school, to work, or you're really just stuck, for that level program, I'm at the Gateway Institute, so it's gatewayocd.com, and that's where I provide the intensive outpatient program. Yeah.
Any last thoughts or anything to leave folks with that I didn't ask a question or we didn't get time to
You
close
know, I think these were great questions. I think the only thing that I do want to say is this is really such a nuanced topic. There really is so many layers. Even as we were talking, there's so many things I didn't say. And I think the biggest thing I want to leave off of is just even from this was, a one-time shorter, right? So if there's more that I think somebody's dealing with, to definitely do your own due diligence and at least go on that website I recommended, iocdf.org. At least minimally go there. Go to gatewayocd.com. There's information there just to start to do a little more research and then start to reach out to some specialists and do your homework, because like I said, there's just a lot of other nuances that come along with this that I think is just commonly misunderstood. So, it's not, I think a lot of people sometimes just think it can be like this light little joke, or it's, like a lot of memes and shows and things like that. But the reality is that it's actually very debilitating. And so I just think that's the main thing I want to walk away with. That by no means that we cover, the depth of breadth, but at least just enough to give kind of like a warm welcome.
Yeah, I love just being able to expose and give more information and even just resources so it is exposed and people don't have to sit and suffer in silence or feel that they're alone. It's more common. Someone I could be, and we're just sitting here and you can mask it so well, and the amount of effort and energy that might take.
That's right.
And so to be able to really get the help that you deserve, just like if you had the flu.
Exactly. And especially, when you have treatment that actually works. Like it works. It's been around for over 30 years, time and time again. I was just at the annual conference in Austin, and same thing. It's still the number one treatment of choice for a reason.
Yeah, I can imagine it afterwards, once you are aware and willing and ready to change, that you get your whole life back.
Oh, absolutely.
Can really then, maintain it as things like you said might come up later, but you've already set a foundation that this is okay, that I deserve to be happy in my life. I deserve to live my best life. I deserve to get the help that I need. So to be able to share that, thank you so much.
Yeah, thank you.
I'm so happy you're here. So thank you. I always end with a hug.
Oh,
so appreciate you.
Absolutely.
And thank you for watching. I hope that you take something away, and I'll leave all of Christina's information in the show notes so you can find her and the resources, and please share this with anyone else that may benefit. Thank you.